So tonight we got Dr. Galton from University of Rochester. Has anybody worked with him in the field before in this room? So he's actually a paramedic with SCQ, right? He's a attending anesthesiologist and a fellow in critical care at the University of Rochester. So very smart guy, a lot of experience in airway management. I think this is going to be a very interesting talk about the role of video laryngoscopy in a pre-hospital setting. So feel free to ask questions, and we got some toys to play with at the end. So.
Thank you, sir. Well, thanks for having me. I need to start off by telling you guys thanks for the presents, because I'm working in burn trauma right now. So the bus wreck of Canadian nationals that you guys dropped off to me, I want to tell you thank you very much. I appreciate the presents. It kept me busy for a while, busier than I wanted to be whenever that was, last week or the week before. So I want to start off by saying we have a bunch of hardware stuff here that we're going to be tinkering around with. I'm getting no coin from any of these companies, so I have no skin in this game. I just have pretty strong opinions. The government really owns me. You know, I know Aaron would agree that once you go through medical school, you rapidly realize that when you start seeing the many zeros behind your student loan debt, it's kind of impressive. So I get no coin. And I have a rule whenever I teach that the only bad question is the one that does not get asked. So you can interrupt me at any point. I would much rather you guys fire questions out, because if you guys are thinking about something, then I'm sure somebody else has the same question. So here's what we're going to do tonight. Goal number one is not to let me talk too much. I would much rather this be kind of a cool kinesthetic night for you guys to play with some stuff. We brought the toys so you guys can check the stuff out, but I think since we have you here, Dr. Farney and I are also going to do a little bit of direct laryngoscopy fundamental work and see if we can beat you guys down with your fundamentals and bring you kind of up to par with all of our neurotic airway management techniques. But we're going to talk about video laryngoscopy. Obviously, that's kind of the primary reason we're here. I'm going to review kind of where it fits in. I think in a lot of cases it's disappointing. We're going to discuss some of the pitfalls of the technology, which is all the stuff that all of the representatives from all the companies don't ever tell you. And then we're going to apply a little algorithm for when I think I would use it as a paramedic if I had it available. And then we're going to talk a few specifics about some of the hardware just to answer some of the questions I've been asked a lot. So I tend to, I always like when I talk to all of my paramedic colleagues, I always flip on this soapbox real quick. So you guys know what this is, right? Anybody ever read Annals of Emergency Medicine besides Dr. Farney? No? Gee. All right. So what is the best way for you guys to make a decent argument to say, hey, Dr. Farney, I think we should be doing something like this? It's for you guys to say, hey, Dr. Farney, did you read this article that came out in the Annals in February of 2016? And he'll say, of course I read it. I read it every month, cover to cover. Every word I have memorized.
I'm a crust.
So,
I read that every month,
but,
cover to cover.
You know, I don't want to say that you know, he's limited to just the Annals of Emergency Medicine. I have no doubt that he spends every waking moment reading every journal that's available, but this is just one example of a very well thought of peer-reviewed journal that if you guys want to be on the same playing field, if you really want to talk the talk and walk the walk, and you want to present new ideas to Dr. Farney, new ideas to MELREMs, and say we should be doing this, why aren't we? We can change the way we're doing this. This is really the best way to start. So if you want to act educated, talk the talk and walk the walk, like when Aaron and I are sitting around shooting or BSing about, did you read this article? This was pretty cool. Maybe we should be doing this. It's all stuff that comes out of reading. So rather than like, hey, I saw this really cool ad in a magazine, and I think we should spend $10,000. What do you say? Goes for the poor. So the other thing is, anybody nationally registered in here? 1. No. 2. Nobody. So if you ever want to get street cred beyond New York State, you really gotta put up the coin and meet the standards that the other, however many, like 35 some odd states meet, since New York State's kind of this weird little bubble that no one else adheres to. So, alright, I'm off the soapbox, I promise. So, what is video laryngoscopy? Who's seen some of these things? Alright, so, there's lots of different stuff up here, right? There's proprietary CMAC, Glide Scope. This is an early version of a McGrath, Interbright, garbage, or I mean, channel devices down here. There's all kinds of stuff, and I'm not even going to talk about some of this stuff. All right, so these are kind of the two that I'll highlight towards the end of the discussion, and I'll tell you why I think if video laryngoscopy has a role in EMS, why I think these kind of devices, this design for devices, is the way to think about going. So, rough guess, it's okay. What do you guys think if I polled everybody in the nation and said, what is the intubation success rate for paramedics? Average adult. You decide they need to be intubated. How successful are we? 50%. Oh, God! If we were 50% successful, would we be intubating anybody? No. No way.
Overall, it's probably in the 70s.
Higher than the 70s. So we're somewhere in between 80 and 90%. So I have a little rule. I don't have too many rules. I try to be an open-minded dude, but this is my little anecdotal rule. And it's when I teach a lot of the emergency medicine people, this is what I tell them too. So I think it's a very reasonable expectation that I, as a medical director, would have of you guys, that I want you to be about 90% successful. 90% of the time, you guys make a decision that I have to intubate a patient. You should have that tube in the right hole. I cut the emergency physicians less slack, and I say, Dr. Farney, I would expect him, same circumstances, all comers, 95%. I'm just winging, and this is not, there's no science behind any of this data. And then I would say, like, I cut myself a little bit less slack and say I should be somewhere around like the 98, 99%. And that's with all the tools that we have available to us, none of this fancy crap. And I think, like, as I analyze my practice as a paramedic, as I become an anesthesiologist and I move forward, that's probably somewhere where I'm in that kind of range. I don't think it's that hard for me to teach you guys all the right fundamentals to get into that 90% range either. So we did, without divulging exactly what groups we've collected data, we have collected some data in Melrose recently. And what do you guys think the success rate for Melrose is? No, that would be the second rate standard. I'm talking about the real deal, the things that's the gold standard. What do you guys think? 85. I would be. Let me tell you, I would be ecstatic if it was 85. Not 85. Keep going. Better than 50. 60. A little bit better than 60. Wow. If you take first pass success rate, we're a little bit better than 60%. If you take all, however many passes have occurred across the board, and this is not every ounce of data from Melrose, this is just some institutions that we've looked at, we're somewhere in the low 70% range, probably.
Is that national rate? Is that regardless of number of attempts per patient? Is that just what the tube was successful in?
So I don't have any solid data on.
I saw numbers that came out of California or something that had similar. I mean, there's been some papers that have kind of slammed pre-hospitalization.
So I would assume, and I don't know this, I would assume you're referring to the pediatric data that came out of Los Angeles. I can't remember. Yeah, like 10 plus years ago.
What it was, might have been.
That's kind of So Los Angeles seems like a haven for like stomping the laryngoscope out of any paramedic's hands. So I will fight the good fight until I die to keep the steel in your hand. Trust me. But more importantly, sorry. So somewhere in the 70s. So sadly, I do not like to admit this. Trust me, but we are not at the national level. Like our data is not at the level of what would be considered a reasonable national standard. So we're a little bit behind. Why are we behind? We're trying to figure that out. And we're going to try to work with you guys to get it back up. Because as soon as we get to awesome levels of proficiency, we can do a lot of cooler stuff. So what is a good goal for Melrose? A good goal in my mind is 90%. Like that would be where I would want us to be. You know, if you said like, hey, across the board we have a 90% success rate with our tubes, then I would be saying like, so now's when we don't need to have. Dr. Farney's going to chest band about this because I haven't told him any of my grand plans. But now is like if you tell me we can have all comers across the board at 90%, that's when I would say like everybody should be an RSI provider. I would say we should be nasally intubating patients. I would say that video laryngoscopy has a place in what we do. Like I would really be pushing for your guys' skill set to expand. In the 70s, most medical directors would be saying things like, should we be reevaluating the fact that we're intubating people? So, all right, next good question, which is why we're here tonight. Can video laryngoscopy help? This is a question that we field in the Division of Prehospital Medicine a lot now. Any of you guys that have gone to conferences, you know that every table at every corner in every conference has a device representative that is happy to try to have you invest in their product because they have the coolest product that can give you 100% success rate and give you a pristine looking airway and deliver that to you every time so that you can put that tube in that hole and everybody's success rate is going to be phenomenal if you use this fancy device that costs a few $1,000s. Right? I mean, that's the pitch. So, is this the panacea? Will technology save us? Hopefully we're going to talk about that.
No.
Can it be cost effective? So I'll throw a few numbers at you guys, and it's by no means ground into steel, but just so you know where you're at roughly. So what do we need to manage an airway? Before we even talk about video laryngoscopy, what do we need to manage an airway? You got to have good airway skills. You got to have good fundamentals. You have to understand the anatomy, and you have to know what you're looking at. You go stick a piece of steel in somebody's mouth and you start lifting, you got to know what you expect to see. I think at a bare minimum, if you expect to manage difficult airways, you should be expected to talk the talk. Or, you know, so if I was standing right next to you, I got to tell you, when I'm working, I work a bunch with Bob Rees and Ben Sensenbach, Lori Clark. Like we work a lot together at SEQ, and I give them a lot of credit because I don't know how you guys would feel, but can you imagine how much pressure it takes to intubate with an anesthesiologist standing right next to you, saying, "Are you going to get the tube in yet? Are you going to get the tube in yet? Are you going to get the tube in yet?" But that's what they deal with. So when they have trouble, I make them use the right terms to tell me why they're having trouble. Or any of the paramedics that I'm working with, any of the residents that I'm working with, any of the fellows that I'm working with, when we're intubating in the hospital. When they say, I can't get the tube in, I want to reach over and smack them, right? What do I need to know? I need them to say, I can only see the right aretinoid. I need you to displace the airway inferiorly for me, or posteriorly for me, or superiorly for me. I can only see the epiglottis. Can you pass me a bougie? I have a Cormack-Lehane grade 2 view. I think I can get the tube in. I'm not quite seeing the epiglottis. Can you pass me a Miller 3-blade? Right? That's what I expect. You gotta talk the talk. You have to use the right phrases so that people understand any difficulty that you're having. If you can talk the talk and you can analyze the problems that you're having, then you can make good decisions about where you need to go next. And you're not just kind of shotgunning and praying that you're going to stick a tube in the right hole and it's magically going to go in. So that's how we're working our way through difficult airways. So I think when people ask me what's going to take paramedics from 90%ers to 95%ers, I got to tell you, you're going to think by the end of this talk that I'm not a big fan of video laryngoscopy, and I would disagree. I'm a really big fan of video laryngoscopy in the right setting. And I think video laryngoscopy in the hands of paramedics that are hitting at 90% is going to be the tool that would take them to 95%. Now, and part of me, this is me internally bashing New York State. Does anybody know what an AENTP is?
That's what we have here.
Yeah. Only New York State knows that. So when you put these initials behind your name and you try to send something to a national publication and say, please publish my article, look at this. Who are you? Nobody uses. I think this is the most ridiculous thing ever. When I moved to New York and I got my, I had to get my New York State card. I was like, what's an AENTP? So NRP. This is me just being condescending. I apologize. All right. So if you're a 30%er, and I'm being obviously a little rough, but if you're hitting 30% of your tubes, do you think video laryngoscopy is going to take you to 50%? No. Because that to me means you can't even get the blade in the right place. So if you can't get the blade in the right place, you put a fancy camera on that, you're still not going to get the blade in the right place. So, and most importantly, you got to know that you're not good at stuff if you ever expect to work on it to get better. So, what do you actually do? Video laryngoscopy, you get this crazy camera on, it's not the same. One of the biggest problems that people have is it's not the same. You don't perform DL exactly like, or I'm sorry, you don't perform VL, video laryngoscopy, the exact same way you perform DL. It's similar, but it is not the same. And it depends on what type of hardware you're using. So we brought, so we ruthlessly pilfered from Cushman's stash, and the one that he carries, or that's on the 906 vehicle, is something that looks like this. This is a McGrath video laryngoscope. Okay, so you can see kind of fairly similar blade to like a standard Mac 3, but not quite. And a little camera, and that's it. Not a lot of rocket science to it. But what do you do? Anytime you have a video scope, you're turning it on, you got to check your equipment just like you would anything else. You got to position the patient. So, I try not to fly off on too many tangents, but I'm going to fly off on one here. How many of you guys love it when you show up, patient's head's hanging right off the bed, and you're like, sweet Jesus, this is it. Like, my life's going to be awesome, I'm just going to be able to stick that tube in, right? Who loves that? Couple guys? Come on, nobody? Two of you guys in the back? You guys, I appreciate you standing up for. So why is it that when an anesthesiologist shows up an intubation patient that instead of taking the head and dropping it off the bed, they do exactly the opposite? You guys ever notice that? You guys ever see when the pros are intubating, they're actually taking, and their goal is to get the tragus of the ear equal to the sternal notch. And that is not taking the head down, that's ubiquitously taking the head and the shoulders up a little bit, right? Primarily the head. So why do we do that? Why does that make sense? Anyone, you guys understand like your fundamental axes, right? I'm going to try and do this the best I can. I just come to do this in cadaver lab, and I couldn't come up with a really great way to explain it. So you have three axes that we're working with, right? The laryngeal axis, the pharyngeal axis, and the oral axis. So let's take, you guys have a name for this awesome dude?
Hal.
Hal, the animal steel, huh? Okay. So let's just say, if we were to look at Hal here, I'm going to pull Hal out of the wall. If we were to look at Hal in cross-section, and we chunked Hal, right? We would see his airway, and we would see roughly his trachea sits something just like this, right? So if my goal, every time that I intubate, is to see down the trachea so I can stick the tube in, shouldn't we be doing everything we can to make that trachea easier to see? And if I took Hal, can I move Hal? Is that all right to move Hal? So I took Hal, and I did this maneuver, and
Watch
he,
it.
and,
Cool.
yep.
I got you.
Don't break Hal. All right. So if Hal wasn't quite as muscular, and his head actually dropped off the bed, would I be correct in suggesting that the laryngeal axis that we'd be looking at would do this? And then what we're really trying to look at is now all the way down here, rather than up here. And really the goal is for me to get that larynx is the easiest spot for me to view, right? So if you guys, all those people who, who've seen people intubated, and you see the blade go in, and somebody's head's dangling off the bed, what happens to the head? Right? It miraculously gets lifted by the paramedic all the way up to this position, and then magically the tube goes in, right? So if you're going to intubate people and physically lift their body with your left arm, I would make the argument that I think it would be a little bit easier if we just put a bunch of stuff under their shoulders and their head to get to this point, and we don't have to lift at all, right? So, all right, Hal, you're going back on that. Hal, you gotta lose some weight, buddy. All right. Thanks, dude. All right, so, and in fact, I think I would make the argument that if I really wanted to improve the laryngeal axis, I want to take the bed up, right? So, Grant, I know not everybody is on a stretcher when we're intubating. A lot of people are on a board. But I would make the argument that if you're really looking to intubate Hal, getting 5, 10, 15 degrees up is going to help your mechanics, because now your laryngeal axis sits like this. Right? Next move. You have the pharyngeal axis. So back in here, right? It sits something like this. It's from the top of the larynx into your posterior oropharynx. Now the reason that you want to get this earlobe equal to the sternal notch is because you're going to take what was a pharyngeal axis, and now you're going to raise that axis all the way up here by raising the head, because the lower end, or the inferior end of your pharynx, is pinned to the top of your larynx, but the head isn't. So you want to take this axis and raise it up. So now I've not only taken our laryngeal axis from flat to increasing the angle, now I've taken the pharyngeal axis that's pinned on the inferior end, and I've raised it up by taking a bunch of stuff and putting it under Hal's head here. So now, all I have to do is just take this oral axis and move it a little bit, and I look right down and drop the tube in. And Aaron and I will show you how easy intubation can get if you actually pay attention to position here. And it's all about the mechanics of lining up those axes. Is that really a word? Axes? The plural of axes. So, and you can see this is the goal. You have obviously this cartoon here where laryngeal axis, which is face down, I think it's probably a little flatter than that, but it's facing down. The pharyngeal axis is flat here, and here's your oral axis. And really your goal is by ramping the patient up, getting to that 10, 20 degrees up off the edge, and then taking something and patting the head, and bringing that head up. You line these axes up, and then the airway's right here. And we'll show you how to very, very easily manipulate the airway, and you're going to end up proper positioning for a patient. You can almost drop a tube down. There's no looking across, you're looking down out of the airway.
And what do we have on every ambulance that we can ramp patients with? We got a lot of blankets, right?
Oh. good stuff. I can tell you that magically, the intubation bag, if this is the one that you guys carry, Karen, you didn't see this? None of your stuff's ever going to get contaminated.
Right.
But that's an amazingly perfect distance. So, hypothetically speaking, it's a good spot, but it's not the best thing because then if you got to flip gear, your stuff's stuck under the head. But, anyone ever seen someone intubated like this? Ow, fire. Don't let the guy work the mouse over here. Right? Not something that's done frequently, but literally this person who's intubating is going to drop. This is obviously the, I don't know that I would intubate people like this very often. But, it's really easy to see the airway when all you're doing is looking straight down onto it. All right, back into, so now we have our patient position. Man, I'm gonna look at this, there we go. So, every time we intubate, you guys should be assessing for, are there gonna be problems or not ahead of time? And then we're gonna go right midline lift. So, you're not looking at the screen yet. All right. He's all right. You guys got a cool medical director. All right. Okay, so just like when we now I'm going to be able to wander even more. This is awesome. All right. So just like when you're intubating anybody else, right midline lift, right midline lift, right midline lift, right midline lift. How often do they pound this into you, right? Right midline lift. Look for what's in the airway. I have a Mac 3. I'm going to put this blade into the vallecula, and then I'm going to push. Right? This device is the same. Right, midline, lift, look. I'm putting the tip of my blade into the vallecula, and now I'm going to lift. And then finally, now I'm going to look at the screen. And this is where the problem with video laryngoscopy in beginners' hands comes around. Is that you have to do the same things, but you get this really, really fancy thing to look at. So everybody wants to look at this. And then when we look at this, we don't look at what this is doing. So, how about some gloves, huh? Take pictures, no gloves. All right. So next, we got the blade in the mouth. In fact, Hal, I'm going to borrow you. So, right midline, we're going to be lifting, and then I'm going to start looking. Right, and then I would look at the screen. Next thing I want to do is actually, I'm placing the endotracheal tube in the mouth the same way I would. I'm not looking at the screen yet. Now I'm going to start looking for the tip of the tube in the screen. And this is finally where we would place it. We would potentially get into the glottic opening, pull our stylet out as our tube's going in. So the big difference that we notice when it comes from video laryngoscopy versus the tube is that the last points of finding the fine-tuning the blade placement, that's what the screen is for. Fine-tuning the endotracheal tube placement, that's what the screen is for. So, this is kind of my favorite part to teach, and it's sad. This is the part that none of the representatives from all these companies that want you to buy all this awesome stuff are going to tell you. So, what happens when your airway is contaminated? So, you've got this awesome video scope, and you're like, sweet, I'm a 30%er, I'm going to become a 90%er because I got this badass screen, that's just how I roll. So, what do you do when you see this? Exactly. You're like, oh! Pass, you got this one. So, what if you had this awesome video scope and you're like, oh. So, if you had DL hardware in your hand and you see this, what are we going to do? We're going to stick the suction in there real quick. You're going to stick your DL hardware in there and you're going to see if you can lift over the puddle and pull the airway out of the puddle, right? And stick the tube in the right hole. Say I wanted to do the exact same thing with this device. What's going to happen? Right. Schmutz is on the screen. How good is this device when the schmutz is on the screen? This device in particular is still able to perform direct laryngoscopy. A lot of the other devices on the market that I'm not going to bash in particular, if it's a one-trick pony device, meaning you have no ability to perform direct laryngoscopy, and you're in the puddle of schmutz, you're done. Game over. You got no skills, and then you're going back to DL, which is probably where we should have started. So, how about this? That kind of sucks. Anybody ever seen the tip of a Mac blade break off while you're intubating somebody? Yeah, me neither. Seen these things break though. What's wrong with this picture? It's kind of weird. So, what's missing from here? Where do you think the uvula went? Went with the blade when somebody stuck the blade in without looking in their mouth and just went, ripped it right off. Oh! Oh, that's not a good complication. Although it's great if you have sleep apnea and you live. Because then you have your uvulectomy or whatever, uvulotomy. Right? So, that's not cool. So, what's that? I'll give you a hint. Oh. That is a stylet going through the soft palate. Any of you guys ever, while performing direct laryngoscopy, decided that you weren't going to look at the tip of your tube? Or maybe you were and you were like, I'm just going to preferentially jam this. I want to do a nasopharyngeal intubation transorally. So I'm going to take my tube and stick it through the soft palate into the nasopharynx. No. When you're performing direct laryngoscopy, you have eyes on the target. Your eyes are on the blade the whole time. Your eyes are on the tip of the tube isn't placing it. Magic, I can't tell you, I've never seen someone jam a tube or jam a stylet through the soft palate while they're performing direct laryngoscopy, but I have definitely seen that. And I have seen that from skilled operators. So that's bad. That would be a tough explanation when you're calling Dr. Farney and be like, so I took the guy's uvula off and I intubated him. I did a transoronasopharyngeal intubation through the hole in the soft palate. So, and if you actually read, this is the most embarrassing part. This is something else that nobody wants to tell you. But if you start reading some of the peer-reviewed journals, there's some pretty interesting articles about soft palate injuries that are related to video laryngoscopy. And there weren't articles about soft palate injuries from direct laryngoscopy all that often. So, seeing is not placing. What is this? So, this is a retinoid cartilage. These are the cords. These are your kind of false cords there. What do you think happened? You've seen this, I know. So what happens? What happens when you video laryngoscopy? This is the thing that drives me crazy. So, how often when you stick? Go ahead, you guys gotta go. That's cool. He's got to like roll for who's getting hammered here.
They're on a fire call.
Okay.
We're figuring it out, Chris.
It's all right. I get it.
I totally get it.
Anything else? No, I got it.
Oh, yeah. So, every sales representative, when you sit down and they want to show you how awesome this device is, or their devices are, they're going to show you how easy it is to get a view, right? And I'm sure Dr. Farney would agree. It's amazing how easy it is to get a view with video laryngoscopy. Does getting a view make a damn bit of difference? No. What makes a difference? Putting the tube in the right hole, right? So there's all kinds of times where I'm sitting there looking at this on my screen, and I have somebody standing next to me making this move. I see it, I see it, I see it. Right? And what does that lead to? This nightmare. This is the nightmare this is a nightmare that we see when we let the first-year resident take a crack at a difficult tube, right? This is probably the view that Dr. Farney sees all the time, where he's like, oh, yeah, resident blew this airway up for me to fix. So, moral of the story is video laryngoscopy is great at seeing an airway. Just because you see the airway does not mean that the tube's going to go in the right hole, though. How about that? What is that? Or this? Right? So your retinoid cartilage is supposed to be right about here, right? Or right about here. What happens when you put a really nice rigid stylet in? Like most of the proprietary devices come with these really nice stylets that they'll tell you, like, if you put our stylet in your tube and you follow it in, you're gonna, and you see the airway, this tube's gonna get guided into that airway every time, right? And those stylets that they give you are pretty darn rigid. They're not fairly malleable like the ones that we use. So what happens when you're like, I almost got it, I almost got it, I almost got it, whack, and you dislocate the retinoid cartilage with a rigid stylet. That's poor form. That's somebody that's going to have a hoarse voice for a long, long, long time. Maybe some vocal cord damage long term, right? Boobs. So, here's my other tangent. Dr. Farney, I'm going to pick your brain real quick. Rough guess. Standard airway. So, someone who you do not anticipate a difficult airway. From the time of you blade insertion to tube conformation on an easy tube with straight DL, how long do you think it's going to take you?
5 to 6 seconds.
Yeah, quick, right? Blades in, find the anatomy, stick the tube in the hole, pull the stylet, bang, bang, bang. Someone's got the end tidal CO2, you get a couple breaths and you're good to go. So maybe long term, 15, 20 seconds, and that's 3 breaths down and you're secure in the airway, right? What's the fastest time you've ever seen anybody do, or on average, first crack, normal airway, for whatever reason, the decision's been made to do video laryngoscopy?
Probably 2 to 3 times as long.
Yeah. 30 seconds, 40 seconds, significantly faster, right? Because instead of putting the blade in, just like I'm telling you guys, right? If you're doing this right, you're going to get in there, you're going to go right midline lift, you're going to use your direct laryngoscopy skills, you're going to find the right spot, you're going to place the blade, then you're going to look at the screen and fine tune. You got it, perfect. You're going to take the tube, you're going to put it in the mouth just like you normally would, and you're going to be looking at the airway, and then you're going to place it, and then finally you're going to look at the screen. You got it, okay, let's pull the style up, we're good to go. Right? It's extra steps. Use the screen. Rather than just right midline lift, place the blades, tube in the hole. So it takes a longer time to do video laryngoscopy for an average normal airway. So, I'm sure you guys know Ben Sensenbach, he's one of my good buddies. He has a 1, 2, 3, 4 rule, which I really, really, really like. This is based on some traumatic brain injury data that came out end of 2014, I believe, beginning of 2015. But first pass success is critical because your second attempt triples mortality. And a single hypoxic event quadruples mortality. So what does that mean to me? That means set yourself up for success. You need to be a 90%er. And you need to be able to work through a difficult airway if it does occur, because now you have a significant situation that's related to high mortality. So when should it be used? So I'm almost done bashing video laryngoscopy. And I'll tell you now that I think it has a place in EMS. I think that place is still up in the minutia. So I think it has a role. So, but I think if you want to use video laryngoscopy, you got to be a 90%er. You got to be able to perform direct laryngoscopy and hit your tubes 90% of your time. And if you get there, the next thing that you have to be able to do is you got to be able to figure out, why didn't I hit the other 10%? You have to be able to analyze. I had difficulty with this airway because of X, Y, or Z. Based on that data, I'm going to decide what the best next course of action is. So you got to be able to analyze the airway. This airway was difficult because, oops, sorry. Real quick, Cormack-Lehane score. So this is me. I would really encourage you guys as you're working through difficult airways to start to talk your way through an airway. And that way when you have somebody, like a good, competent partner, they're going to be able to help you because they'll know what you're seeing without directly seeing it themselves, right? So, Cormack-Lehane, grade 1 and 2 airways, these are ones that you're just going to stick the tube in. The data is not exact, and I have to apologize that I didn't bother pulling these numbers from some awesome source, but this is just kind of, you know, me anecdotally saying, I would wager to say that, and Dr. Farney, you can disagree with me, but 85 to 90% of patients that you guys are going to see are grade 1 or 2 airways. Like, all comers, drop dead, all the calls you guys are going to go on. Would you agree?
I would agree with the caveat that part of the problem with folks who aren't hitting 90% is they're not getting that view when they probably could.
Yeah. So this is, I'm sorry, thank you, maybe I'll clarify. This is when you position the patient properly, pick the right hardware. Almost everybody you see is an easy airway. Trust me. Somewhere, you know, then you get into these grade 3 airways. This is, you know, 5, 6, 7, 8% of the patients. And this is every time you see this, you should just be like, pass me the bougie, right? Bougie slides right into the epiglottis, and then railroad your tube right down. Now we're getting into grade 4. This is in the single-digit percentages, certainly. I think I would tell you the number of grade 4 airways that I've seen in my career in EMS, I could probably count them on less than 2 hands, and I've probably, I don't know, I'm just going to guess that I've had, you know, many, many hundreds of tubes in the field. So really, what's the problem? When do we need toys? When we have grade 4 airways. So, if you see a grade 4 airway and if you get contamination, that's pretty easy. You get blood, you know, mucus, whatever is in the airway. You're going to suction the airway out, or you can just throw a rescue airway in. You're not seeing the epiglottis because you picked a too small of a blade for your patient. You're just going to pick a bigger blade, right? This is where video laryngoscopy can help a skilled direct laryngoscopist. And that is when you have an airway that is very anterior. When you have something that you see grade 4 view, mainly because you have somebody who has a small mandible, short neck, very small thyrohyoid distance, and you're sitting there saying to yourself, I know the airway's up there somewhere, I just can't physically see it. Now, video laryngoscopy can definitely help you here. Because video laryngoscopy can make that bend. It can show you what's very anterior that you can't otherwise see. And hopefully you can get a tube there. So this is just acronyms that anesthesiologists use. Cannot intubate, cannot ventilate. Cannot intubate, cannot oxygenate. So this is somebody who you're trying your darndest no matter what you do, and you can't ventilate them, you can't get a tube in right off the bat. You're gonna default to your supraglottic airway at that point. And then what do you do when you're in one of these situations and the supraglottic airway doesn't work? Surgical cricothyrotomy. Needle cricothyrotomy. You're moving to invasive management. So, does video laryngoscopy have a role here? I totally think so. But I think if you're actually going to use it effectively, you gotta be a good laryngoscopist. So you have to know, I'm gonna nail these tubes, I'm gonna have these patients in good positions, the majority of them I'm gonna hit. When I don't hit them, I have the skill to know why I'm not hitting them. And I'm gonna make the appropriate adjustments. In some cases, the video laryngoscope might be that adjustment. I think in a lot of other cases, there's other adjustments to be made too, though. So, last but not least, and then we're going to get to plan. Let's say you still want to spend the money. This is totally me asking around, talking to a bunch of people that sell some of these devices. So, the device that the Division of Pre-Hospital physicians use is this McGrath device. So I gotta tell you, I think highly of this device for one simple reason. It is a enhanced direct laryngoscope. What does that mean? This device can perform direct laryngoscopy, and it has a tool that makes it a little bit better. Right? This device, if the power goes out, you get schmutz on the scope. There's no channel that your tube is stuck in. Right? You're not completely dependent on the video. You can use this blade just like you would use any other blades and stick the tube in the hole. So we love that idea. Yeah, I'm sure Dr. Farney would agree. I know Dr. Cushman loves it, and that's why he decided to purchase this device, because you have options. Right? You're not stuck with this video scope. You have a good blade that 90+% of the patients you can intubate without even using the scope. You get a pretty reasonable picture. You guys will see, because we're going to play with this, but it's very light, really compact. We have this awesome, I don't know, Cushman must think someone's going to try to throw a grenade at this laryngoscope, because this thing looks like it'll take a beat down and a half, but you can see that there's not much to this. There's a couple blades, little piece of plastic. This can get really, really compact really quick. It's a short startup time. So you guys will see, like, pow, video's on. So the blade's on like that. And that's what you want. You want EMS devices, you need something that you're going to turn on and it's going to go pow. You can see there's a little number on the screen that says exactly how many minutes of battery life you have. So you're not sitting there wondering, like, oh, I think the battery's dead. Again, about $2,500 or so. There's obviously a lot of variability to that. Each one of these disposable blades runs you about $18 or so. So hardware's not super cheap. I'm a little bit of a snob because I'm an anesthesiologist. I'm biased. I apologize. I really like this McGrath thing, and I would tell you that, if it was my budget that this device is coming out of, this is the one I would have, not this guy. But this thing's called a CMAC. It's super expensive. The reason that I love this thing, and I absolutely love this thing, and this is something that essentially I get to use in the ORs all the time. It's a little bit different, but this device, this is a battery pack that slides right out. This whole handle and this blade come together. You can clean them, you can autoclave them. So there's no disposable parts anymore. And all the blades are the traditional blades. So you get the benefit of the video scope. This is a hyper angulated blade, which I really don't like, because you can see airways and you can't put tubes in. But you can get a standard Miller 2, Miller 3, you can get a Mac 3, a Mac 4. You carry them all, and essentially you have the same exact blade that you would on the same exact handle that you would have, plus a little camera. So I think this is the stuff that is perfect for what we do. And then you could be intubating every time using this hardware, and then if you have a difficult airway, you just turn the screen on. They're heavy. You'll see that this thing is, this is supremely light. This device is significantly, it's like the steel handle you guys are used to. The blades you can autoclave. There's a lot more to carry. You can see these disposable blades. There's multiple sizes of these little blades, and it's just real small. This is a pretty big handle to carry, so the amount of hardware you would carry is significantly more. And the device and the blade, somewhere around $7 grand, and some places a lot more than that. So pretty steep. So before I end, I want to just make the point that I really do think that video laryngoscopy has a place in what we do. I don't think it has a place in what we do yet. I think once we get people to the point that we have a bunch of really skilled laryngoscopists that can work their way really through a difficult airway algorithm, then they would know the role of the video laryngoscope. Otherwise, we're stuck with each time you intubate somebody, it's going to cost you $18, and you really didn't need it 90% of the time or 95% of the time. So that gets to be really, really expensive. Replacing the batteries all the time, that's really not a necessary expenditure. So that's all I got. I wanted